Hello and welcome everyone to Change Agents Learning and Action Network. My name is Deborah Huber. I'm the Executive Director of Health Insight Nevada, coming to you live from lovely Las Vegas. In this case, what happens here won't be staying here, as we are being joined by colleagues in at least 3 other states and in locations such as we have here in Las Vegas, and also online from parts hopefully that we'll know sometime soon, because you'll chat in and tell us about that. This is really a first-of-a-kind event. We call it a Mega LAN, Learning and Action Network. We really like acronyms, and it's pretty mega considering the number of people and the many ways that people will be joining in. So I want to tell you a little bit about who we are. Health Insight is here's a mouthful coming, a quality innovation network, quality improvement organization. We have that designation because of a contract we have with the Centers for Medicare and Medicaid Services. We have a number of other designations as well, but our real purpose for being an organization is to transform healthcare. As I mentioned, we have in-person participants in 4 states today, and we'll also be having some online participants as well. So a lot of what we're going to do today is about interaction and reaching out to each other, and so I really want to start with that. And so a couple ways that we could do this. For those of you online, you should be able to see your chat widget on your screen, so you can click on that and chat in where you're writing from, and what I'd like you to do is answer the question, what was it that made you laugh out loud yesterday? What made you laugh out loud yesterday? So you can chat that in. If you're in a room with another person or many people, what I'd ask you to do is turn to somebody that you don't know, introduce yourself, and tell them something that made you laugh yesterday. You know, maybe it was one of those crazy Columbus Day jokes. You know, those can really, they can really be funny. Whatever the case may be. And so we'd ask you to do that. Again, there's possibilities. If you just hang on just 1 second. Oh, go for it. You have 50 seconds to do that. Okay, all right. Maybe you got an extra laugh also. Vern, maybe ring your bell. Thank you. Well, I hope you shared a chuckle or a laugh with someone. I see our chat moderator laughing over here, so maybe there's one funny you want to share with us, Wyatt?
Yes, thank you, Deborah. We have Barbara chatting in that a resident yesterday started to feed the CNA for a change.
The resident in the nursing facility fed the nursing assistant instead of the other way around. I'll tell you, I laughed out loud yesterday. We have recently rescued a little dog 6 months ago, actually, and it just gives me such pleasure and joy. She's just really come into her own, and every morning she just runs around like a crazy, grabs her toys, takes them outside, runs back in. I mean, it's just a pleasure. It's just a pleasure. So thank you for doing that. We're going to have breakout like that every so often. I wanted to mention that we are providing continuing medical education, and we'll be providing the session is designated for 4.25 Category 1 credits. And these are the members of our planning committee and also our speakers. Want you to know that we don't have any relevant financial relationships that we need to disclose to you. So if you want CME or CE, you need to note that on the sign-in sheet. And if you register, if you're participating online, there was a note for you to be able to click that as well. We'll be sending your certificates in about 10 days or so. And again, if you have questions about that, you can just chat those in and we can give you some instructions if you don't know how to do that. Another good resource for those of you online is healthinsight.org/change agents. It's where you went to register to begin with. Okay. So, again, I'd like to introduce your hosts for today. We're Health Insight. We're a regional healthcare collaborative, and our work focuses on transforming our healthcare system with goals to improve individual healthcare delivery, make healthcare more cost-effective, and to improve the overall health of our population. Much of our work is funded by Medicare or other federal or state agencies, but we also have private contracts, the largest of which is here in Nevada. Health Insight manages and operates the only statewide health information exchange, and that's a private organization called Healthy Nevada. So we at Health Insight have invited you to participate in a learning and action network, a LAN, as I mentioned earlier. Well, what in the world is that? Well, it turns out that all four of those words are really important. First being learning from our speakers, our thought leaders, and from each other. And so it's not just learning. It's action. So during the course of our time together, we're going to ask you to take some action to become a change agent and think about what actions you can take after you leave today. And then networking. We know we have many creative participants joining us today, and together we're creating a network of like-minded folks, of colleagues that are interested in transforming this healthcare system of ours. Folks who may think that they're facing unsurmountable odds or insurmountable barriers. But you know what? There's probably folks in this room and across the online that have maybe faced a similar barrier and might have just a suggestion for what you might do, or might have the answer to the question that you've been trying to figure out about a change that you want to make. And so it's really the network as we pool our resources, because this is a heavy lift. If we could have figured out how to fix our healthcare system, we would have done it long ago, because we've got a lot of smart people working on it. So it's really a combination of that learning, the action that we take, and the network that we create to do that. So this meeting is really only the first. It's sort of a kickoff. We will be doing these large mega lands on an annual basis, and then we'll have what I call the mini lands every quarter. We'll pick a specific topic about becoming a change agent that will help you create and develop those skills more, and we'll do those on a quarterly basis. And we'll let you know more about that, about how to register and how to participate in those. So as we seek to learn from each other, I wanted to make sure that you are aware of that we have a poster gallery. So in each one of our sites, we have posters that some of our participants have put together for us. Online, you also have a gallery to look at, and the address is right there for you. And so we really want to thank the folks that took the time to share what they've learned, to share the initiatives that they're participating in. I know that they would welcome your feedback, your questions, talking to them about how maybe you can replicate something that they've done in your own organization. So again, please take a few minutes at break or at our hour-long break when we end the plenary to take a look at those. So each of you should have your change agent action book. It's something you're going to want to hang on to. I'll tell you that right now. So it kind of gives you an overview of a lot of kinds of things. Again, for those online, you should have gotten the link to that in your email yesterday, but it's also at the Health Insight website. So just going to draw your attention to a couple of things. You can use the workbook to jot down some thoughts, jot down questions, ideas about things that you might want to do when you get back home. If you have particular aha moments that you want to make sure that you remember, that's a good thing to do within the workbook. So again, our today's agenda, our morning agenda, pretty straightforward. As I mentioned, we're going to stay on time and walk through a number of different elements here. When our Voice of the Patient session is concluded, I'll provide a wrap-up with a little bit more detail about what's going to happen this afternoon. Basically, we'll be taking a 1-hour break, and we'll say thanks and adios for just a little bit to our online participants. They will then rejoin us in the afternoon, dial in for our breakout sessions that we have planned. So people that are in a room with others, we'll have separate rooms for breakout sessions, and our online folks will dial in. And again, I'll give you some more instructions on that at the end of the morning session. Remember, we talked about action, kind of the big word in the title, action plan. So within your workbook, here's a template that you might want to think about and use. We're going to ask you at the end of the day to begin to prepare an action plan for becoming a change agent, for making those changes back home in your sphere of influence. And here's I think, kind of a thought-provoking, ask you some questions about things you'd like to change, people you've met that you'd like to follow up with, posters that were interesting to you, and good ideas that you've gained. We'll have the sessions where you complete those facilitated by a Health Insight staff person, so you can get some assistance with that. We're going to ask to collect those, and so that we have an idea of what you're working on and what technical assistance we might be able to provide you with that work. So that'll be at the end of the day today. Questions and comments. Because of the way that we're set up, we're not going to be able to take live questions like you might normally just raise your hand and ask the question or comment, but we still want those questions and comments, and we've got, again, a number of different ways for you to ask those. You can chat those in, and the chat moderators will let the speaker know what those are. In some sites, you have even a little cube that have these quick reference codes. The codes also are in your action book. And so if you can scan those into your phone and then ask your question or make your comment as well. If you're in person, you should have some note cards in front of you with a pen. You can write down those questions and comments, raise your hand, a staff person will pick those up, take them over to the chat monitor, and they'll get chatted in that way. You can also use the QR codes if you prefer to do that as well. So please don't hesitate to ask those questions and share those comments, and we'll take them to the extent that we can. It's likely that you might ask more questions than we'll have time for. Our plan is to answer those questions and post those on our website next week so that you'll have that opportunity to get that answered. Okay, here comes another fun part, all right? So next time, here it's ready to vote, okay? No politics involved, though, okay? So here's what we're going to do. The question is, when is the last time you took a full week's vacation from work? When's the last time you took a vacation, full vacation from work? Okay. So your possibilities here are A, I just got back from vacation. B, the last 6 months. C, last year. D, what's a vacation? Okay, so those are your options. Now, to enable to vote, you can do this in a couple of ways. You can, again, go to the pollev.com that you see listed on here, Change Agents LAN, or you can text it in. And let me give you the instructions about how you do that. So in the text, in the to section, the address to, you put in Change Agents LAN. Change Agents LAN. It's not case sensitive, but it is one word. Okay, so you type that and you'll get a message back from Health Insight. Then in the to box, you're going to put the numbers 22333. 22333. And then in the message, you'll put what your vote is, A, B, C, or D. Give you a minute or so to do that. Do we have success? Can I see some nods? Yes? Success? Yes? Okay. So let's see what we got here. All right, so I'm pressing my slides to see my results, and I'm getting nothing here.
If you push it too many times.
Okay.
Go. Right, touch screen.
While we're getting there up there, I know you're interested in my vacation. And so I did go in the last 6 months. We went in August. And we went up to Vancouver. You know, it was really, really hot here this summer. It started getting hot in June and way too hot. And, I hadn't been to Vancouver before. So we went to Seattle and drove up to Vancouver and, over to Vancouver Island and the flowers. And it was just fabulous. I highly recommend it. And I highly recommend vacation. There was a lot on the news actually yesterday. I noticed that, some of the companies are giving unlimited vacation, and that's kind of freaking people out when they take less because they just don't know what to do about that. But it did also said that about 50% of us don't take all the vacation we're given, and about 60% of us work on the vacation. So I don't know if that's really a vacation.
Just go ahead and go.
Okay, and tell her I've got till 10 after, I think. Okay, well, I guess someone will tell me what the results of the poll are, and hopefully we can get that fixed. Oh, we have them over here. Thank you.
Yes, I can provide those results.
Thank you so much, Wyatt.
Excellent responses coming in on that poll. We have a total of 170, and it continues to climb as I'm watching, with the greatest number having taken a vacation within the last 6 months.
Oh, good. Thank you. I wonder if we asked in the winter if it'd be the same, or people go on the vacation in the summertime. I don't know. Anyway, another way that you can reach out is to tweet. So if you're active on Twitter, we would ask you to use this hashtag ChangeAgentsLAN, and talk about your experiences today, what you're learning, what you're sharing, what you're thinking. So again, we have lots of options. We can actually talk to each other if you're in a room with somebody. We can chat, we can vote, and we can tweet. And now I've lost my Tracy. But I'm going to start by keeping you on your toes here. Well, I still might need some assistance here. See if I can get rid of this. Okay, so change agent, that's what we're all here about. And so here's some ideas. I'm going to ask for quiet in the room if I could. Here's some ideas about what a change agent is. I think it's somebody with a vision for what can be, and who can tap into the strengths of others and see how they can be used in a way to work toward a common purpose, not maybe in the same way or with the same exact idea, but moving us forward anyway. This doesn't have to be the person with the ultimate authority in your organization. In fact, most of us here who want to be change agents are not the authority in our organizations, and that doesn't matter. I think it's a person that asks tough questions, that questions the status quo, and says, "Why not?" A change agent leads by example and takes risks, even suspends disbelief that, you know what? The healthcare system has been the way it is for so long. Can we really make a difference? And the answer to that is yes, absolutely so. You can be that change. You're here today to get some strategies, some practical advice, some ideas about what we might do differently where we work, and to begin to talk together and network about what needs to happen. So I'm just going to ask you today if you will commit to being the change you want to see in our world. That said, we're going to turn it over to our first speaker. It's my great pleasure to introduce one of my favorite change agents. If you watch any national conferences on healthcare reform, payment reform, you're likely to see him, whether it's on a panel for the Brookings Institution or participating in the National Quality Forum or on a program for Medicare. In addition to all of these other positions he holds, some listed here, we know him as a quiet and thoughtful man, a man who inspires followership, and a man who is a man of vision and integrity. It's not the Pope. It's our own Mark Bennett, President and CEO of Health Insight. Mark?
Just going to take a minute here to adjust this, I think. Apparently I'm a little bit taller than Deborah, so I'm also really grateful for the opportunity that I have to be with you here today, and to spend a few minutes with you talking about how healthcare payment reform affects our future and the opportunities and the threats that it brings to us. I thank you, Deborah, for that very kind introduction. I appreciate the opportunities that I have to be involved in this space. I have to tell you that I don't consider myself a true expert in healthcare payment reform. I'm not really sure there are experts yet. This is very much a field in flux. There's a lot of stuff going on, and there's a lot of people working, but there are not a lot of perfect or clean answers. And the results that we're seeking are more aspirational than they are things that have arrived and that we're enjoying the full benefits of at this point. But I do spend a lot of time with people who are working on this space. And I do have 25 years of working and trying and sweating and failing and succeeding at trying to bring about change at a community level in our healthcare system. And I have the scars to show for that. Many of them are scars related to early efforts to try to change how payment works in our system. And so I guess that makes me, in some fashion, an expert. And so I'm grateful for the chance to be here with you. Today I'm going to move through a number of slides, and I'm going to do so fairly quickly. We'll have some time along the way to talk at your tables about vision a little bit in a few minutes. And we're going to try once again to do a poll, so hopefully that will work for us and we'll be able to get a little input from the broader group. But there won't be a ton of time And because of the nature, there won't be a lot of face-to-face interaction or direct questioning interaction. We'll have some questions at the end that will be moderated by Wyatt through the polling feature. So if you have a question during the course of the presentation, we want you to write it down on one of the pieces of paper and hand it to a Health Insight staff member. We'll take it and we'll enter it into the polling function, and they'll be available at the end for questions. I've also put my email address on this opening slide so that we can continue the dialogue after today wherever you are. If you have questions or you want to engage, I'm happy to engage with you over email or in a future opportunity. I want to begin my presentation today with a small analogy. This cell phone belongs to my mother-in-law. She was goaded into buying it by her children and her grandchildren. And I think she was perfectly fine with the little, a simple cell phone that had a keypad on it with all of the numbers she needed to dial. But her kids didn't think that was near cool enough, so they convinced her to go and get an iPhone. And, this is a really powerful tool. It's a great resource for managing information and for managing communication. But sometimes we lack the vision or the understanding of how to take full advantage of that capacity. It can help us solve problems, but we lack the ability or the desire or the capability to really take full advantage of that. And as a result, sometimes we turn such a powerful tool into just a bulletin board. When my mother-in-law got her iPhone, the first thing she did when she got home is she turned it over and she taped a calendar onto the back of her iPhone. She didn't understand that resource was almost instantaneously available inside the iPhone, or at least she didn't understand or believe that she would be able to quickly come to use that tool. And so instead, she reshaped the tool to something she did understand and was familiar with. In some way, this is not unlike our situation in healthcare. We have what I think is almost unlimited potential to alleviate suffering, to improve lives, to provide dignity to people. But collectively, we sometimes limit our capacity to act on that because we don't have the vision or because we don't have the tools that are necessary to utilize the full capacity of healthcare to meet those needs. And we also tend, and I think this is important as we begin and discuss this presentation, we also tend to take that transformation that we're engaged in and reshape it back to something that makes sense to us in our former world, as opposed to really embracing vision and innovation and moving forward to change the system. Change is hard. Change in healthcare actually is really hard, not just hard. It's really hard. I've not known of any more negatively resilient system anywhere in the world than the American healthcare system. It actively resists change, and there are forces at play that are very powerful. American healthcare represents a fifth of the U.S. economy. And there are lots of people, most of us in this room, frankly, who draw a paycheck every week and are dependent upon that system. So it's not surprising that making changes to it is difficult. Most of us, I think all of us working in healthcare, want to see healthcare transform. That's not the issue. I think the real issue is we want to see it transform in ways that make our particular part of the system work better, or our lives easier, or our work more enjoyable and more focused. And this is the important and, I think for all of us, almost all of us, our second best choice to the change we want, the way we want to have it happen, is status quo. And that's why healthcare is so hard to change. It's not because people don't want to see it change, but the visions of what we want to see change are so varied and so different. It's also true that the pace of change in healthcare is not smooth and even. It's more like a pendulum going back and forth. Sometimes you feel like you're making progress, and then it just kind of moves back to the other end of the fulcrum. It's also capable of very sudden shifts that change your world overnight. And so it's not just a stable system at all. And then finally, the last thing I'd just comment for you to begin, sometimes even when change is happening, it doesn't feel like anything's happening at all. I hope through the course of our discussion today you'll get a sense of how we are close to one of those sudden shifts and that a lot of change really has been happening. More than a decade ago, the Board of Health Insight challenged us to move beyond creating small incremental changes through our projects and to look for ways to influence the larger system, to begin to reshape healthcare to make it more affordable and to improve the overall outcomes. We developed a model at that point of interrelated efforts that we thought we needed to work on all at once in order to move beyond incremental change to transformation. These included simultaneously working on sharing clinical data across the continuum of care, optimizing the use of health information technology, using transparency of cost and quality data to enable and engage consumers and the broader policymaking community, changing workflow and care processes, engaging consumers in their own decision making. And all of this had to happen in a system where payment worked to support that kind of change. It became very apparent to us that the transformation we seek could never be done alone, that it had to be part of a larger community effort, that people had to band together to make it happen because it was too complex and too multifactorial for a single entity to drive. Today we've been asked to talk about what it means to be the change. That's the theme of our conference today. So what does it mean? Well, to me, it means that all change is personal. In the end, you can only really make changes to your own work and to your own attitudes and to your own views of how you engage with others in the system. Each of us have to make that choice, and when enough of us make it together, the system will begin to transform in the way we want it to. So why do we need to transform anyway? I'm going to try through the course of today's presentation to give you a little bit of data about why we need to change. But the upfront message is we need to change because everything around us is changing. We have to change or we will be left behind. And our society cannot continue to afford the healthcare system the way that we continue to operate it today. And third, how do we begin? At the end of the presentation, I'll try to offer you a few ideas about where you can begin in order to make some progress along this path. This is one of my favorite quotes from a favorite childhood story. I'm sure many of you have heard it before. But in spite of what the Cheshire Cat said to Alice, the truth is you're never going to get anywhere useful unless you know where you want to go. No matter how long you keep walking, you still won't get anywhere useful. So what I'd like to do is ask us to stop here for a minute and talk together in small groups. There's a page in your workbook for those of you who have a workbook. Either talk individually or in small groups for just about 5-7 minutes about your preferred vision for the healthcare system. I'd like you to be as concrete as possible using this idea here. So how would your day be different as a provider or a patient or a payer or a policymaker if healthcare redesign and transformation occurred? and how. And so just write a few things down, talk amongst yourselves. Again, if you want to, I'm going to try to gather some of these in. So at the end, if you could write down your idea and pass it over to a Health Insight staff member, we'll also enter it into the chat and can be part of our larger discussion. So we'll take about a 5-minute break now, and I'll give you a 1-minute call as we come back together.
But in the poll, or in the, it has to be in the presentation. You have to restart. You have to restart. I don't want to restart.
What's the next
I don't know where Tracy is, but now it's saying you have to
We're about 1 minute away from restarting, so if you could work towards writing down your best idea and submitting it in, that would be helpful. Okay, we're going to get started again, so if I could have your attention back up front in the room or wherever you are, I'd appreciate it. So thank you for taking some time to talk about your vision and the potential of the system to transform. If you write down your ideas on a card and pass them to the moderator at your session, wherever you are, or if you're on the chat, if you enter them into the chat, then we'll be able to review those, and we'll come back to this after a few minutes, after I go through a little bit of data. I do want to begin by taking a look at some data to help us understand the urgency for change that exists, and a little bit about the efforts that are now underway to change how we pay for health care in our system. Paul Batalden said, "Every system is perfectly designed to get the results it gets." This is a really important idea in quality improvement. It's the core of systems thinking. And as we go through these slides, I want you to think about what system produces these results, because I'm just going to walk you through some key results in the American healthcare system right now. Americans are overweight and obese. And more importantly, that the number of obese Americans is growing exponentially and very rapidly. Over the last 20 years, you can see tremendous growth in that. There are a lot of reasons for this, a lot of causes that we can point to. But the bottom line is this is a big problem for health and healthcare now and into the future. We also see diabetes growing rapidly. This is an expensive, complex chronic disease. It requires a lot of healthcare resources and attention. The growth of this and other chronic diseases has a profound impact on healthcare in the United States and on its ability to fulfill its core role of helping patients get and stay well. There's also in our nation substantial variation in healthcare quality and cost that crosses both geographic lines and within a given geography from one provider to the next. This has been measured time and again by numerous studies over time. And importantly, these disparities, these differences, while some things are improving, there's a lot of this that seems to resist change when we try to work on solving issues. Medicare and Medicaid have now grown to become the largest driver of healthcare spending. Together, they exceed considerably spending on defense, spending on Social Security, spending on the national debt. They are a major driver in our system. In fact, President Obama said it this way: our healthcare problem is our deficit problem. Nothing else even comes close. So consider that as we talk about some of the challenges that our nation faces. In addition, we're seeing a substantial shifting of costs as more of our healthcare system depends upon more of our dollars in the economy go to healthcare. The American system is becoming less and less competitive. This graph shows data, you've seen similar data from other sources, I'm sure, of how much of our GDP is spent on healthcare in the United States versus other countries in the industrial nations in the world. And that's leading to very large increases in costs for both employers and maybe more importantly, directly for employees as those employers attempt to limit their exponential exposure to the growing healthcare burden costs in their industry. Effectively, because of this continuing trend, the rising cost of healthcare has eliminated almost all real income gains since the turn of this century. It's all been eaten up in healthcare. And according to the President's Council of Economic Advisors, worsening health, medical technology arms races, volumes, overvalue work, these kinds of issues should matter to each person in the United States. Individuals, because it's stealing your pay raise effectively. So remember, every system is perfectly designed to get the results it gets. We produce a lot of good in the American healthcare system. There are lots of people who benefit every day from the interventions that come because of the system being designed the way it is. But these are also the results of the American healthcare system. And it points to the challenges that we face going forward. Given that environment and given that reality, the federal government is really engaged quite actively in the process of trying to influence and change the current performance in our system. This slide is taken from, I just want to make sure I get my notes in the right place here. This and the next several slides are heavily influenced by CMS. So I borrowed heavily from the work of Patrick Conway, who's the deputy administrator at CMS, and I think one of the chief architects of the federal response to the need for healthcare transformation and to payment reform. Basically, what you see in this slide is CMS is saying we need to focus on incentives. We need to focus on changing care delivery, and we need to focus on better information being available. Their goal, their version of the triple aim, better care, smarter spending, healthier people. And in order to achieve that, they think they have to really influence all three of those nodes at the same time. If you understand this context and you look at these next several slides, my hope is that what you'll see is where CMS is headed and also what their attitude is about that and why they feel both that it's successful and urgent to move ahead. The Health and Human Services Department set a very aggressive goal at the beginning of this year. The goal was to achieve 85, well, I think it's better in this slide to show. They went from 0% 5 years ago, care being delivered through an alternative payment model within the Medicare fee-for-service system, to a goal for 2018 of half of all Medicare fee-for-service being delivered within an alternative payment model. As you can see in those circles for 2014 and their projections for 2016, they're starting to make progress towards that goal. It is a very heavy lift. There's a lot of things going on, a lot of challenges that this environment creates. But I believe CMS will get there. I believe their will is sufficient. I believe their resources to act on this, to work on this problem, are sufficient. Some think unlimited. Maybe some who are negatively inclined say obscene how much money they have to work on this, but it's actually a very small amount of the spend. But they're very committed to it, and they're spending a lot of resource on it. And I think they're going to get there, and that is going to change our world, I think, in some fairly dramatic ways. It's not just Medicare that's working on these kinds of alternative payment mechanisms. This graph shows state Medicaid agencies who passed and are implementing alternative payment models for their Medicaid programs. Over just a few years, this graph grew from 0 to 15, and it continues to grow as Medicaid grapples with the challenges that they face. And it's not just government. In the private sector, in private insurance, this graph from Leavitt Partners, and Leavitt Partners is a leading private entity working in, among other things, study of ACOs and helping providers implement ACOs. They show in their projections that by 2020, 72 million Americans will be covered under an ACO at the current pace of growth in that area. Some of these efforts are beginning to show success. And some of us may think the successes or even the programs designed to change the payment system are a little bit pedestrian. Sometimes I feel like when I'm frustrated with CMS that they're really just dabbling in payment reform, that they need to move faster. But they have reason to believe they're making success. And the data to support that, I think, is pretty strong when you read it across the articles out in the system. And so there's a real interest and a real power, a real potential for the kind of change that I think CMS is looking to bring about. They've seen over the past several years what could only be seen as dramatic reductions in hospitalizations and costs associated with hospital care in the American Medicare system. And they attribute that at CMS to a combination of factors, including improvement programs like the QIO program that we're here under the auspices of today, or the hospital engagement network activities that have been going on around the country. They also attribute it to the quite modest payment incentives that were implemented under law over the last several years and that have put some pressure on hospitals to reduce unnecessary hospitalization. And they attribute it to some of the public reporting initiatives, the compare websites, other more aggressive programs, and more recently the introduction of qualified entities. All of these things have produced for CMS a significant evidence of change of these programs working together to bring about the changes we seek. According to the CBO, we're also seeing the Congressional Budget Office, a nonpartisan group, a fairly sharp decline in the projections of Medicare spending, partly based on the changes in the ACA, partly based on the economy, partly based on these improvement activities. But these are evidences that the current CMS leaders are using to say, this is working, we need to do more of it. This is evidence we need to more aggressively move towards change. And so, armed with these successes, and frankly, feeling the pressure right now of the tension that their successes creates, what we're creating by working the way we are in alternative payment models is we're creating for providers the experience of trying to navigate on a lake with one foot in two different canoes, where you're trying to stay balanced, and part of your resources are going to fee-for-service, and part of your resources are managed under population health models or under more value-based models. And that tension can't hold. You'll tire, or we'll go back to the old models, or we'll have to move forward. And so CMS is saying, we're going to move forward. We're going to be more aggressive about this. So they've started to create more aggressive ACO models. These models are intended to be more predictable in their financial targets, provide greater coordination opportunities, and importantly allow beneficiaries to select their own ACOs. In turn, they allow for prospective attribution. A big problem in the current payment reform efforts in government so far is that attribution has only happened retrospectively and without people knowing about it, the patient knowing that they were being attributed to a given provider. It also is going to allow CMS to better reward quality under these new models and allow for enhanced collaboration and coordination support across the system. And finally, and importantly for smaller ACOs, they're going to try to smooth out the financial picture to allow the cash flow to work a little better for those who don't have very large amounts of resource available to them. This is all happening at the same time that Congress just passed the MACRA legislation. MACRA basically was the SGR doc fix bill. This is the law that did away with the annual dance that the Congress would do where they had said they were going to cut physician pay to follow the sustainable growth rate formula, and every year they would go to that line and then say, well, we're going to put it off and we'll make docs whole for another year. And then as it got bigger and bigger, so the rates, every time if they didn't act, in theory, we were going to cut physician pay by 20, 30, 40%, depending on how the overall economy was looking. And that was not a sustainable idea. It was never going to work, but they could never figure out how to change it. Well, this year they did. They passed that law, and now CMS is hard at work trying to implement MACRA. And MACRA includes really a strong push towards pay for quality or a strong push towards alternative payment models in two ways. One, it introduces under the MIPS system enhanced incentives for reporting and outcomes in value-based outcomes and quality, replacing the existing systems. It's a more demanding system. There's more reporting requirements. There's more work in it. There's also more dollars at stake for providers. But I think most importantly, they've also introduced a move towards alternative payment models that allows for incentives for providers who switch from just fee-for-service with these little riders to more aggressive models like accountable care organizations or bundled payments or global fee arrangements. And the payments for these are made on a lump sum annual basis, 5%. And way more important, I think, in the end for the typical provider, they provide, in addition to the incentives, they provide relief so that that provider isn't going to be overwhelmed by the MIPS requirements, which are demanding. And many providers, I think, will choose this path as they come to understand the alternatives available to them. In addition to payment changes, CMS is also working on making information more available. They've used the Quality Compare websites for a long time. Mostly that has been indecipherable information that nobody really used. But they're making a doubling down bet on information availability. They're changing the game in a number of ways, including more aggressive data releases like the recent release on by physician on Medicare charges that they're betting on that creating buzz and energy that can be used to change how we think about information and to change behavior of providers. They've also been more patient-centric in some of their more recent systems. So the star rating systems are tested as being much more likely by patients to be usable and useful to them. And they're trying to take advantage of the huge investment that they've made in electronic health record adoption to begin to use clinical data to enhance the public reporting data that's available. And finally, they've been made some investments to move that data not just inside of CMS, but out to entities in the communities where they serve who can, in return for getting that Medicare data, are tasked with public reporting it at the community level and at the provider level. So that's meant to give you just a little flavor of where CMS is headed and what's happening in the world around us as we think about payment and the importance. I want to pause here now and ask Wyatt if we can get maybe just if you could read one or two or three of the comments that may have come in.
Yes, thank you, Mark. We have a lot of great chats, comments coming in. A lot of them focused on the perspective of the patient, which is interesting. One of those, in my ideal world, healthcare entities would work collaboratively and closely to provide excellent care to patients or residents. This would include sharing resources and pooling finances to improve relationships and increase available workforce.
Thank you. So, any others? Anything? How about something pretty concrete? Anything in there that fits that? How my day is going to be different?
Yeah. So, here's one coming in from the Utah audience. Engage all team members who care for our patients to be more empowered to take a team approach. I think this helps us meet our patients' needs in a more holistic way.
Okay. So team-based care, patient focus. I'm really glad to hear that. We're going to come back to patient focus again in just a minute, but I think that's sort of a core principle. And thank you all for participating. I hope those of you who are online, this might be one way because we're funneling everything through that. It might be one way, excuse me. Sorry to race you through those. Where I think we can give those who have the disadvantage of not being in the room with us a little bit of advantage in the discussion as well at the same time. So thank you. So next I'd like to just spend a few minutes with you talking about principles that I think are necessary if we're going to be the change that's going to lead redesign. The first of those really is it's all about the patient. So we just heard from a couple of our participants about that. I think if we lose sight of this principle, we lose sight of everything in the end. There's so much of healthcare now that is aligned around the needs of the provider or the needs of the legacy system that we have in place to keep it running or the needs of the financial model that we're running. But that's always been backwards. I think we all know it's been backwards. And this is a great opportunity as we make this payment transition to think about redesigns that take the patient to the center, family to the center, that designs the system around the needs of the people who we're trying to serve ultimately. My belief is, in the end, that will make healthcare better, and it will make healthcare better for us that work in that system as well. The second principle is that bad processes beat good people every time. Now, this is a quote, or it's actually a paraphrase of a quote from Dr. Deming, the father of quality improvement. And it's really designed to remind all of us that it's the system every time. Almost all of the challenges we face are products of the system design that we've chosen. And it's almost never a people problem. Even though in our media-starved world and in the public square, we often act like almost all of our problems are designed to bad actors, are attributable to bad actors in the system. What Dr. Deming teaches us is, no matter how good the people are operating in that system, if you don't design a process that works to allow them to succeed, in the end, that system will overwhelm them and they will fail. It's a really important principle in making change happen. The third principle is that we need to eliminate waste. I'm really asking all of you to make substantive changes in our healthcare system. We can use lean technologies, we can use quality improvement methods to find and eliminate waste that may be present in our system. This exhibit from a health policy brief describes, and there are many of these out there, and they all come in about this same range. Basically, it says that between 1/3 and 1/2, and almost 1/2 of all healthcare expense is waste. And so when we talk about the changes we need to make in order to be more patient-centric, in order to be more team-based, if we could just figure out how to eliminate a portion of that waste, then we could do these additional things that need to be done without adding cost to an overburdened financial system that can't take more cost. It needs to make the changes without adding resources. So eliminating waste becomes the critical success factor in driving towards change. Now, I would say about this is not easy. This isn't like going to the butcher and cutting off the fat from the edge using a meat cleaver. The fat, the waste, almost all of it is marbled into the value add. And so the technologies that you're going to learn in today's session, that you're going to learn on your own as you move forward, are really what are going to allow you to make that transformation happen. The fourth principle is run to space. Now, this is really about the ability that separates good from great organizations, I think, and it's knowing where we need to be in the future and knowing how to get there. Wayne Gretzky famously said, "A good hockey player plays where the puck is. A great hockey player plays where the puck is going to be." And that's a really powerful concept. Before I ever heard Wayne Gretzky say it, though, I heard Don Berwick say, "Run to space." Now, he made this analogy very real for me in his own style that is really powerful. And I don't know if you ever heard him give a national forum address at the Institute for Healthcare Improvement, but it's really a pretty impressive thing. In his 1995 forum speech, which was one of the first I ever heard, he described his experience coaching his daughter's fourth grade soccer team. And after a lot of characteristic humor, dry humor and some, kind of real wit and wisdom imparted in the course of that, he showed how the team's success on the field and by extension our success as leaders in healthcare depended on running to space, on being where the ball was going to be when it was going to be there, not on just chasing the ball around the field. And he also described, and this is a critical part of his talk for leaders, this notion, this importance of understanding how the game is played. This is a non-delegable task. You have to know as a leader how to make improvement happen, how the process works of changing the system. And if you don't do that, you're never ultimately going to be able to be successful as a coach or a leader in our healthcare improvement efforts. The fifth principle is don't fear failure. In fact, failure is a necessary part of improvement. It's the only way, it's one of the best ways that we learn. It's perhaps not the only way that we learn. This graphic is taken from a report on the 100,000 Homes campaign. Sarah Woolsey, our medical director in Utah, shared it with me, and I thought it was really apropos to the principle we're talking about today. In this example, I think you can see the same kinds of things happening in healthcare that were part of their discussion about homelessness. That the mottos, the worldviews, the beginning premises that we operate with, the protocols or processes we run, the use of data, what we do when things go wrong, how we follow up on mistakes. The difference between failing as an outcome and failing as a catalyst to improvement is notable, and it's really important for organizations and for individuals who are trying to lead change. Number 6 is respect the limits of rules and incentives. This is really important to me in a talk about incentives, really. Ultimately, that's what I've been assigned to tell you is, hey, financial incentives are going to change the way you behave. And as you lead change, I hope you'll understand that there really are limits to those rules. This applies to incentives. It also applies generally to to rules. So the Checklist Manifesto, I don't know if you've read this book. It's a wonderful piece of literature. It shows the value of standardizing processes, and it shows that the benefits of building checks into our system that are respectful of the limits of human memory. Our ability to sort of keep things in presence in our minds is limited, and so the use of checklists is a really powerful tool to drive change. But standardization needs to be understood and respected as having its limits. If not, it will always lead to bureaucracy, and bureaucracy will always stifle innovation. So we need to be respectful of that. Similarly, in the incentive space, better alignment of those incentives and better efforts in that space will help us as we try to change and drive towards cost management. It's critical to help us align and move to the results we seek. But I think we also have to be really vigilant here, because at its base, and there are plenty of people in the political environment we work with, and even in the debate about healthcare from a policy standpoint, who are of the view that it's all about incentives, that if we just change the incentives, everything will be better. Well, I think we as an audience are sophisticated enough to understand the limits of that idea. In fact, what we want to be vigilant against is that transition where we reduce the professionalism and the moralism of individuals trying to serve people down to, hey, it's just about the money. They're Pavlovian in their response, and that's not the case. That's not what we're trying to do. My view is what we're really trying to do is get financial incentives to the point where they can basically be neutral, so they don't harm our ability to pursue the right thing in the interest of our patients. I'm going to move fairly quickly through a couple of other principles here. Deming said, management's overall aim should be to create a system in which everybody may take joy in his work or her work. That's a really important part of a successful healthcare system. And I don't think there is a lot of joy in the American healthcare system the way it now operates. Far too many people feel like they are joyless, like the joy has been sapped right out of them. So, I want to test that theory for just a minute. So we're going to do a quick polling question. And I'm going to ask you again. Now, you should have if you already did the poll with Deborah before, then you should just be able to send a text to 22333 that has the number, because you've already registered. If you didn't do that first step, and then you need to register by sending a text. They're sending change agents land to that 22333. But otherwise, just take 30 seconds, register a vote, and then Wyatt will share some results with us as they come in. Where are you on the joy spectrum in your work today? Any numbers coming in, Wyatt?
Yes, we do, Mark. We're up to 200 and still increasing.
Okay.
If you were to see the bar chart, you would see starting at number 1 as their response at 6 responses, and then this huge lift up to number 8 with 50 responses, and then 9 and 10 dropping back down to 20 and 9.
Okay.
8 is the winner.
The peak of our curve. So we have a lot of joy in our work in this room, comparatively, and I think that's great. I think that actually speaks to the energy that you bring to your work. I hope that our system can help you support and continue to grow that because it's essential to success. I'm almost out of time, so I'm going to be quick about the last few slides. This is a statement from Peter Drucker. Culture eats strategy for breakfast. And, that's true. And Peter's not the only one who said it. In fact, it's been said by lots of leaders in healthcare over the last, lots of leaders in business over the last 25 years. It's become almost a trite, popular phrase in the healthcare environment. The reason it's so popular, though, is it's really true. And it's one of those things that leaders in organizations, every time I encounter this reality, it's really humbling to me, because what it says really is, you're not very much in control of this beast. And I mean, that's really what it says, because I can affect strategy, or at least I can affect what our organization's strategy is, but I can only influence culture. But it also says if I work on influencing culture and make that my strategy, I'm more likely than not to succeed, and the rate of success is going to be much faster. I want to close with just two thoughts. Reiterating, transformation is coming. It is both necessary and it's inevitable. You're not going to be able to stop it. If your goal is to ride it out, that's a bad strategy. It's not going to work for you. This transformation is going to come. So we hope you'll join with us in helping make it happen. And second, joy really is possible. You can do it in a way that makes your work much more enjoyable every day, makes it much more tangible to the success you're seeing. I was going to pause for a few minutes on the next few slides. There are several slides which we'll hand out that show a couple of examples of that at play, but I'm out of time. And so thank you for allowing me to visit with you today and spending time talking about this important work you're engaged in. Thanks.
Out of time. Well, I guess that would mean you don't have time for questions.
So I'm told I took too much time. I don't have time for questions, but I am sincere in my offer. So if you have a question that you want to ask me by email or engage with me, for those of you in the room here through the course of the day, I'm happy to visit with you. Thanks.
You do to me here. Oh, we didn't get to. That's okay. That's all right. Thank you, Mark.
Okay.
So now we're going to have a 15-minute break, and so we're going to be back promptly at 1:15. Again, let's chat. Online folks, just click on that widget on your screen. We'd love to see what you're chatting about, your experience, that hashtag ChangeAgentsLAN, ChangeAgentsLAN. And if you're in a room with other people, please interact. And we'll see you back here sharply at 1:15. And online people, stay tuned. We'll be right back with you.
Take it down and bring it back up.
Oh, okay.
For the poll.
Oh, okay.
It's like you're really expecting
Scroll down to the bottom.
I don't know where my. Oh, I had to close this out.
Okay, yeah. We lose him again. Lose Terry. Okay, so then if we go down, you gotta close PowerPoint all the way. Yeah.